Alterations in elimination, gastrointestinal, disorders of the liver, gallbladder, or pancreas. The liver has four lobes and is supported by mesenteries that connect the liver to the intestines, the abdominal wall, and the diaphragm. It is going to metabolize glucose, protein, fats, drugs, chemicals, bacteria, and foreign elements. It helps convert glycogen to glucose and helps regulate blood glucose levels. Excuse me. It stores vitamins. It forms and excretes bile and bilirubin. It synthesizes factors for blood coagulation. Liver function is not significantly affected unless disease is present. Jaundice is a greenish or yellowish discoloration of the tissue. It is not a disease of itself, but it's a symptom of disease, usually of the liver or the pancreas. It results from an abnormally high concentration of the pigment bilirubin in the blood. It's visible notably on the skin and the oral mucous membranes, and especially the sclera. There are three forms of jaundice. We have hemolytic jaundice, which is from an excessive destruction of red blood cells, hepatocellular jaundice, which comes from liver disease, and obstructive jaundice, which is from blockage of bile between the liver and the intestinal tract. True or false? Jaundice results from an abnormally low concentration of the pigment bilirubin in the blood. And we know this is false. Fibrosis is a chronic degeneration liver disorder that's caused by cellular damage. We have irreversibly damaged liver cells. And consequences of these damaged liver cells means that it's affecting our digestion and metabolism, our fluid and electrolyte balance, and it impairs our ability to metabolize hormones and detoxify chemicals. We have several different types of cirrhosis. Alcoholic is going to be the most common, and it's caused by chronic alcohol intake or poisoning or ingestion of hepatotoxic drugs, such as acetaminophen. Post-necrotic cirrhosis, excuse me, is the destruction of the liver cells secondary to an infection, disease, or exposure, once again, to hepatotoxins. Biliary cirrhosis is scarring around bile ducts in the liver from chronic biliary obstruction and infection, or an autoimmune liver disease. Non-alcoholic steatohepatitis is a buildup of fat. The prognosis of cirrhosis will be dependent on the bilirubin and albumin levels, ascites, neurological involvement, and nutritional status. These clients may have compensated and decompensated symptoms. Chronic fatigue, anorexia, dyspepsia, nausea, clay-colored stools, and diarrhea are common. Constipation, tea-colored urine, or even a yellowish colored urine, abnormally yellow. Weight loss and abdominal discomfort may be present. Shortness of breath, nosebleeds, signs of incomplete estrogen metabolism in men, and the enlarged liver and or spleen, along with jaundice, are all symptoms that may be seen with cirrhosis. We diagnose cirrhosis by a liver biopsy, blood tests, CT scan, MRI, and radioisotope liver scan. These are going to demonstrate the liver's enlarged size, nodular configuration, and distorted blood flow. Remember, if we do a biopsy, this is a highly vascular organ. So the risk of hemorrhage is very high with a liver biopsy. So it's very important to monitor for hemorrhage. We treat it supportively. There's no specific cure, but basically we want to prevent further deterioration. We need to administer vitamins and nutritional supplements. No alcohol. With advanced liver disease, we need to restrict protein intake, maybe administer lactulose and or do a liver transplant. Lactulose is going to help bind the ammonia in the body to help prevent hepatic encephalopathy. And we'll talk more about that as we go along. Ursodeoxycholic acid, potassium sparing antidiuretics, sodium intake regulation, platelet transfusion, and liver transplant are also treatments. As far as nurses, we need to be sure that we monitor vital signs, weight, intakes and outputs, and the abdominal girth, especially if they're developing ascites, which we'll talk about momentarily. These clients require small meals and moisturization of the skin. One of the symptoms we see with liver disease is going to be pruritus. The liver helps metabolize a lot of the medications and the toxins in our body, and if it's not functioning appropriately, one manifestation from that is going to be the toxins in the skin causing pruritus. We also need to monitor their response to any drug therapies, monitor for mental status changes and signs of a GI bleed. We also need to teach the client about this disorder and hook them up with some support groups, encourage them to follow their treatment regimen, and instruct them on specific home care needs. Complications of cirrhosis include portal hypertension. The portal vein runs through the liver, and then with the portal hypertension, the blood is beginning to back up in that portal system, meaning it's going toward the esophagus. We may see congestion, pressure, a GI bleed, ascites, and encephalopathy. We treat it by restricting sodium, administering drugs, and potentially inserting a shunt surgically or non-surgically. Excuse me. And esophageal varices, these are going to be like varicose veins that are located in the esophagus, or like hemorrhoids, which are basically varicose veins around the anus. But they're going to be very fragile areas. It results from that increased portal hypertension. So it causes those esophageal blood vessels to begin to dilate and begin to bulge. They become very fragile, they're easily traumatized, and can very easily cause esophageal bleeding. And that esophageal bleeding can be so severe that it becomes life-threatening. Sclerotherapy may be necessary, variceal band ligation, or the Singleton-Blakemore tube might be required. We're definitely going to administer IV fluids. It may require blood products and a soft diet. We don't want the client to be eating foods that have a rough texture, because even just that friction from that rough texture of the food can rupture those blood vessels. So we also want to avoid straining. So we don't want the client to be straining to have bowel movements. Uh, so we're going to give stool softeners. And we want to minimize chemical irritation because all of that can easily traumatize those blood vessels and cause bleeding. Ascites is collection of fluid in the peritoneal cavity. With the hepatorenal syndrome, we have serum protein that is leaking into that cavity, so this fluid is going to be high in protein. To take care of it, we do the abdominal paracentesis, where we actually drain off some of that fluid, or we can do a surgical insertion of a catheter into the abdomen, and diet and drug therapy, such as diuretics. Hepatic encephalopathy is a central nervous system manifestation of liver failure. Coma and death might happen with this. We have increased ammonia levels in the blood. The CNS effects that we see are going to be disorientation, confusion, personality changes, and asterixis. We need to eliminate dietary protein, administer lactulose to help get rid of that ammonia, and remove residual protein, in addition to depleting intestinal microorganisms. Hepatitis is inflammation of the liver after exposure to drugs or chemicals, alcohol abuse, or infection. This can be an acute issue or it can be a chronic issue. Hepatitis C may include injectable recreational drugs where we're passing that disease back and forth when we share the needles. Hepatitis B is a fecal oral route. This is, again, a viral infection with A, B, C, D, and G. Type A will be transmitted in water, food, or medical equipment that has been contaminated by fecal matter. It is rarely fatal. Type B is found in all body fluids of infected persons, transmitted by intimate contact with carriers and contact with contaminated blood or medical equipment. 6% of people infected past the age of 5 will develop chronic hepatitis. There is also an increased risk of cirrhosis, liver failure, and liver cancer with Hep B. Type C is transmitted by contact with contaminated blood and medical equipment or infected body fluid. Some people will recover from type C, while some will develop chronic infections or liver cancer. Type D is transmitted through the skin and mucous membranes. There is also an increased risk for chronic disease and possible liver failure. Type E would be similar to type A and is transmitted through food and water contaminated with infected fecal matter. This type is pretty rare in the United States. Type G is going to be transmitted through blood transfusions. Hepatitis B, C, and D can be chronic and persistent. Types B and C are very common with hepatocellular carcinoma. Other types can include autoimmune, toxic, and drug-induced. There's 4 different phases with hepatitis. We have the incubation phase, where the client is asymptomatic. The virus is in their blood, bile, and stool, and they are infectious at this point. Then we have the preicteric or prodromal phase, These clients will begin to have nausea, vomiting, anorexia, fever, pain in the right upper quadrant, rash, and urticaria. With the ecteric phase, the clients develop jaundice, pruritus, clay-colored stools, dark urine, and fatigue. In the post-icteric phase, the liver is enlarged, the client has malaise, fatigue, and the liver tests may start to return to normal at this point. So we need to diagnose with serology analysis and a liver biopsy. Treatment will be symptomatic. These clients should be put on bed rest, which is also called liver rest. They will receive IV fluids, a balanced diet, vitamins and antiemetics if they have nausea, vomiting, and drug therapy. They may require liver transplants, and if so, then they will also be on immunosuppressives. So it's really important as nurses to educate on transmission prevention, complication prevention, avoiding alcohol and liver toxic medications. Now, there is also hepatitis vaccines. The most common one is hepatitis B. This is going to be a series of 3 injections. It can be given as early as birth. It should be given to all children, healthcare workers, and adults that have diabetes mellitus. So which type of hepatitis is passed by the oral fecal route? Type A. Liver tumors are abnormal masses of cells in the liver. They can be benign or malignant. They may be a primary tumor or it may be a metastatic lesion from the breast, lung, or GI tract. Benign liver tumors may be caused from tuberculosis, fungal, or parasitic infections. And tumors can cause bile obstruction, jaundice, liver failure, portal hypertension, and ascites. These clients will exhibit jaundice, right upper quadrant pain, liver enlargement, and ascites. We diagnose through blood tests, liver scans, ultrasounds, MRI, CT scan, or biopsy. We can do several different medical or surgical things, such as a hepatic lobectomy. We do not have to have the entire liver to survive. We may only need one lobe. We can do cryosurgery or cryoablation. We can do IV chemotherapy or infusions directly into the hepatic artery or peritoneum, in addition to other drug therapies, and chemotherapy or radiation therapy. We need to ensure client safety and comfort and provide support ventilation, administer medications appropriately, and teach the family and client on what to expect, what to do, and hook them up with support or referrals. Gallbladder. Cholelithiasis are stones in the gallbladder. Choledocholithiasis are stones in the common bile duct. Cholecystitis would be inflammation or infection of the gallbladder caused by the formation of stones, chronic or acute. Risk factors are described as the 5 F's, being female, fat, fair, 40, and fertile. And the risk for cholecystitis also increases with diabetes. When we have cholecystitis, we have bile stasis. Dietary factors can also cause cholecystitis. Infection, gallstones that impair the passage of bile. We have inflammation of the gallbladder, and then it becomes distended with bile. These clients may have belching, nausea, vomiting, discomfort. They can have some pretty significant pain, and that pain can be exhibited in the shoulder and also epigastric. It can mimic myocardial infarction pain. The discomfort will be the result of the inflammation and the contractile spasms, especially after high-fat meals, because we have a reduced amount or absent bile. There may be swelling, necrotic gallbladder. We may see slight jaundice and light-colored stools. We're going to diagnose this through a cholecystography, CT scan, ultrasound, radionuclide imaging, PTCA, ERCP, or an MRC. We can treat it by putting down an NG tube, especially if there's a lot of nausea, vomiting, antibiotics, parenteral fluids, low-fat diet. Remember, the gallbladder is storing bile. So if there is an issue with the function of the gallbladder, it's not releasing bile when it should. And high fat is going to trigger the release of bile. So if we eat a high fat diet, bile is not there, causes pain. Lithotripsy to help break up stones, a sphincterotomy, a laparoscopic or open cholecystectomy. A laparoscopic cholecystectomy is usually going to have approximately 5 small incisions on the abdomen for the insertion of the scope and the camera and the lights, etc., to help remove that gallbladder. An open cholecystectomy is going to be a diagonal type incision located in the right upper quadrant. Post-surgery, a T-tube may be inserted to drain bile, and that will be for a period of time before it will be finally removed. Nursing management, pre and post-op care, drain care if there is one. We may have to teach the client how to drain that T-tube and how to care for the insertion site if they go home with it. Even after surgery and the removal of that gallbladder, clients should avoid high-fat foods. And we also need to educate on medications. Pancreatitis is inflammation of the pancreas, and it can be acute or chronic. With acute pancreatitis, we have the mild form and severe form. With the mild form, we just have inflammation and edema of the pancreas. With the severe form, we now have enzymatic digestion of the pancreas. In other words, the enzymes are now beginning to digest or eat the pancreas. We may have necrotic tissue, local and systemic complications. So basically what's going on is that autodigestion from a reflux of bile and duodenal contents. We see swelling of the pancreatic duct and destruction of the pancreas, potentially caused by structural abnormalities, abdominal trauma, infection, irritable bowel disease, or alcohol. These clients have severe mid-abdominal to upper abdominal pain radiating to the sides and the back that increases after eating and vomiting is very common. They may have frothy and foul-smelling stools. They may have signs of steatorrhea or fat in the stools. And they may have jaundice or hypoactive bowel sounds and hypotension. We diagnose by looking at serum and urine amylase, lipase, and liver enzyme levels. We also need to monitor the blood glucose levels and white blood cell counts, low serum electrolyte levels, CT scan, and maybe endoscopic examination. With chronic pancreatitis, causes would include alcohol, hereditary predisposition, hyperparathyroidism, autoimmune pancreatitis, trauma, and anatomic abnormalities. These clients again have severe and persistent pain, digestive disturbances, flatulence, vomiting, diarrhea, dark urine, secondary diabetes, light-colored stools, and weight loss. We diagnose with CT scans, MRI, ultrasound, and endoscopic retrograde studies. We treat it by abstaining from alcohol, eating a fat-free diet, and correcting associated biliary tract diseases. Drug therapy, we may give something to help with pain, and this would include narcotics. And we may also give non-opioid analgesics and pancreatic enzymes. It may require a partial or total pancreatectomy. It is very important to monitor for life-threatening symptoms, monitor the blood glucose levels, and INO. People can die from pancreatitis. Pancreatic cancer can occur in the head, body, or tail of the pancreas. Basically, we have an accumulation of malignant cells that block the pancreatic duct and cause symptoms similar to chronic pancreatitis. Pancreatic cancer has a rapid growth and usually a very poor prognosis. Factors that correlate with pancreatic cancer include diabetes, high-fat diet, and chronic exposure to carcinogens, excess body weight, and family history. This disease may be really advanced before symptoms are noted. They may have left upper abdominal pain, jaundice, anorexia, weight loss, obstructive jaundice, pruritus, ascites, light-colored stools, and dark urine. We can do diagnosis with abdominal ultrasound, CT scan, and biopsy. We can treat it with ablative procedures, a radical pancreatoduodenectomy, also known as a Whipple procedure. This will basically remove the head of the pancreas and resect the duodenum and the stomach, redirecting the flow of secretions from the stomach, gallbladder, and pancreas. We could also do a cholecystogeganostomy, where we reroute the pancreatic and biliary drainage. And for tumors that are inoperable, radiation therapy or chemotherapy. These clients usually are going to require palliative care. Postoperative care and prevention of complications are important. Monitoring for bleeding and infection, and client teaching on medications and how to monitor their blood sugars. True or false? The Whipple procedure is the removal of the head of the pancreas with the resection of the duodenum and the stomach and redirection of the flow of secretions from the stomach, gallbladder, and pancreas. This is true.